Hello again, and I'd like to continue on the PowerPoint, and we're going to continue with the first type of anemia groups, which is called the macrocytic. Macro being large cell, megaloblastic is a sort of another term for macrocytic. So you can at this point just use those interchangeably if you see this megaloblastic. It's a little bit different than macrocytic, but it still means a big cell. So macrocytic, normal chromic, big cell, but the color, the heme is normal. There's nothing wrong with the color. It's just the size. So these types of anemias, these macrocytic, normal chromic anemias are characterized by large stem cells in the bone marrow, and they develop into large size red blood cells. So they're big. They're just too big. The most common etiology for a macrocytic anemia is vitamin deficiency in two different vitamins, one of two. So somebody can have a vitamin B12 deficiency or a folate deficiency. They don't have to have both, one or the other, and they lead to a macrocytic anemia. That's very important to know. So when you study, you're going to put a title of macrocytic normal chromic, and underneath that, you'll put vitamin B12 deficiency and folate deficiency. Those are the two types of anemia that go under this category. So vitamin B12 deficiency is the most common etiology, and it's generally dependent on dietary intake, right? Taking enough foods that have vitamin B12 in it, okay? So somebody can have a vitamin B12 deficiency because they're not taking enough vitamin B12. We give them a supplement and hence they're okay. But there's also something called pernicious anemia. And pernicious anemia I'll talk a little bit more about, but it is also a vitamin B12 deficiency. And it is caused by an absence in this intrinsic factor, which I'll talk about in the next slide. So that's very important to know as well. So there could be two causes of vitamin D deficiency, just simply a decreased intake and a kind of like a hereditary type of autoimmune process that a patient doesn't have this intrinsic factor, so they can't absorb vitamin B12, and that's called pernicious anemia. The second type of anemia we're going to talk about is a folate deficiency. So there's just two different anemias that go under this category right here. So let's talk about pernicious anemia. Pernicious anemia is a type of a megaloblastic anemia and is caused by vitamin B12, which is cobalamin, deficiency due to an intestinal malabsorption. So pernicious anemia has a problem with, the person has a problem with B12. They may be taking B12 pills and they're taking all the supplement, but their gut can't absorb it. So they have a B12 deficiency, and that's the cause of it. Absence in intrinsic factor, which is essential for the absorption of vitamin B12 in the ileum. So we have intrinsic factor in our belly, and that is important so we can absorb B12. If they're missing this intrinsic factor, like I said, they can take all the B12 they want, they're not going to absorb it, and they will have a chronic vitamin B12 deficiency, which is pernicious anemia. So individuals with autoimmune pernicious anemia commonly have two types of antibodies, and this is important because we can test these, and they are an antibody to the parietal cells in the belly, and the other is an antibody to the intrinsic factor, which we all should have in our belly, but they may develop these antibodies against these, and so hence they don't have these. So when somebody has a vitamin B12 deficiency, it's important that you know that there's two lab tests we want to check for, and it's the antibody against parietal cells and intrinsic factor. Those have to be checked because if they have an antibody to one of these two, then it's going to dictate how this person gets treated. Versus if they don't have an antibody and the only reason they have a B12 deficiency is because they're just not taking enough B12 in. There's other causes. It could be congenital, like I said, they're having just inheriting it, acquired conditions that damage the belly, like H. pylori, somebody who's diabetic, some thyroid autoimmune, Another place that this is not uncommon is somebody who has any surgical removal of the stomach, or somebody who has a bariatric surgery. They have the sleeve for weight loss. They have that. They often will manifest with a vitamin B12 deficiency because there's some type of damage to one of these antibodies, or one of these factors right here. Smoking, alcohol can certainly contribute to it as well. What are clinical manifestations of pernicious anemia? So pernicious anemia develops slowly over about 20 to 30 years. Or so by the time the individual seeks treatment, it's usually pretty severe. So it's something that takes a while to manifest. Early symptoms are often ignored because they are nonspecific and vague, like infections, mood swings, GI, cardiac, kidney issues, just maybe some vague complaints. So sometimes it's not picked up right away. When the hemoglobin level has decreased to 7 or 8, the individual experiences classic symptoms of pernicious anemia, which are weakness, fatigue, and I have some that are highlighted. So I'm going to go through these and tell you why I highlighted these. Paresthesia of the feet or fingers, difficult walking, loss of appetite, maybe it's just kind of some GI problems, right? Weight loss, just again, because of these things, loss of appetite and abdominal pain, that could certainly lead to weight loss because they're not going to eat. A sore tongue that is smooth and beefy red, which we call glossitis. So the things that I have highlighted here, two main things that I want you to know as far as clinical manifestations. Let me just kind of rewind a little bit and tell you, when I talked about anemia in general, people with anemia have all the same general symptoms we talked about in the first part of this PowerPoint, right? But then some specific anemias have specific symptoms. So some specific symptoms to pernicious anemia are neurological manifestations. They have some neurological symptoms, and sometimes that's how they manifest. They have paresthesia of their fingers and their feet. Maybe they lose their balance and they're falling, difficulty walking. So I could put multiple neurologic manifestations here. These are just kind of two that we see in these type of people, especially when it gets severe and the hemoglobin gets down to 7, we start seeing neurological symptoms. The second one, with the vitamin deficiencies, with the B12 and the folate, there are the tongue changes. So they generally have this sore tongue. It's kind of smooth because the taste buds all get just kind of flattened down. It gets kind of red and beefy, and we call it glossitis. So just a sore, smooth, red tongue can be a manifestation of somebody with a pernicious anemia. So two main things that are specific, the tongue and the neurological manifestations here for pernicious anemia. So how do we evaluate it? So the diagnosis of pernicious anemia is based on the clinical manifestations that we just talked about, test results demonstrating in a macrocytic. Well, how do we know macrocytic? This is super important to know. I'm going to definitely quiz you on this. Macrocytic, they have a high MCV, big cells volume, okay, normal chromic, the MCH and MCHC are normal, that's not a problem. We can draw blood and send it for a serum level for B12, those are low, so that's a pretty good clue, right? And confirmatory studies include the detection of the circulating antibodies against the parietal cells and intrinsic factor. So somebody gets a CBC. Maybe they have some symptoms. Maybe you just don't know what you're looking for. So you draw a CBC. In the CBC, you see that they have a high MCV, which should lead you to think they have a macrocytic anemia. You can draw some lab, get some B12, get some folate, since those are two anemias that are characteristics of the high MCV or the macrocytic. And so once somebody gets a B12 level drawn and the B12 is low, the next step, which is a very important step, is to draw for these two things right here, the parietal cells and the intrinsic factor, to see if they actually have these antibodies, or is it just a nutritional deficiency? That matters, right? And it matters right here. So replacement of B12, vitamin B12, which is cobalamin, is the treatment of choice. So we're just going to replace it, okay? Initial injections of B12 are administered weekly. They get them every week until the deficiency is corrected, and then they get monthly injections. And it says for the remainder of the individual's life. Yes, if they have the antibodies. If they have the antibodies, if they're positive for the antibodies against these two cells here, yes, they will get these injections the rest of their life. If these are not positive and it's just a deficiency, once their B12 levels come up, we can stop the B12. The other thing that's important to know here, if somebody has a vitamin B12 deficiency, they get the injections and then we get their B12 level up, then they can take oral B12 and they can take it every day and just to keep their B12 level up. But if somebody has positive for the antibodies against the parietal cells or the IF, they have these things are positive, they can't take oral. I mean, they can, but it's not going to work, right? They don't have the ability to move that B12 through the gut. So this person who has pernicious anemia, because they are positive for one of these antibodies, they will get replacement for the rest of their life. Again, if it's just a deficiency and they don't have these antibodies, we can get the level up and then they can stop taking it. Blood counts return normal to within 5 to 6 weeks. And if somebody has pernicious anemia, like I just said, with these right here, it cannot be cured. So the second one I want to talk about is the folate deficiency anemia. A deficiency of folic acid results in a megaloblastic or a macrocytic. Remember, these terms can be used interchangeably. Anemia having the same pathologic consequences as those caused by vitamin B deficiency. So they're both two deficiencies that certainly have consequences, which lead to a macrocytic anemia. Folic acid is an essential vitamin required for RNA and DNA synthesis within the maturing erythrocyte. So you got to have folic acid, you got to have B12 so this erythrocyte can mature. Humans are totally dependent on dietary intake of folate to meet the daily requirements. You don't have to memorize this. So folate is completely from diet, fruits, vegetables, that kind of the green leafies. It's estimated that at least 10% of North Americans are folate deficiency. That's 1 out of 10. That's a lot. Increased amounts are required for lactating and pregnant females. They have to have more folate. We've talked about that already. And deficiencies of folate can cause the neural tube defect in a developing fetus. So hence, again, the prenatal vitamins are important. Folate deficiency occurs more often than a B12 deficiency. And it is not uncommon in somebody who has alcoholism or they're just somebody who is chronically malnourished because they're not eating food. Typically, these two groups of people aren't eating food. And so we see a folate deficiency typically in these two groups of people. But sometimes we see it in somebody who has inflammatory bowel disease like ulcerative colitis or Crohn's. And it might actually be the reason why they have any type of vitamin malabsorption. There are always, other reasons that could be causing a malabsorption. So what about clinical manifestations? They're similar to those. And then there's specific ones for the folate deficiency. Number one, this cheilosis, which is scales and fissures of the mouth. So they get these like inflammation of the mouth and these sores in the mouth, stomatitis, inflammation inside the mouth right here. You can kind of see painful ulcerations in the buccal mucosa and the tongue. So they get some ulcerations on their tongue, and sometimes their tongue could have like big kind of ridges in it, big fissures in it, like big cracks and stuff in it. So sores inside the mouth and inflammation inside the mouth. So that's specific to a folate deficiency. So you can see vitamin B deficiencies, whether it's the B12 or the folate, can certainly cause some problems in the patient's mouth. So that's something to think about in your differentials. So the evaluation and the treatment for evaluation, again, we're going to see a macrocytic red blood cell, which is a high MCV in the blood. And we can just measure the serum folate levels. We just draw it and see what their folate levels are. If they're low, we need to supplement them. Treatment requires administration of oral folate preparations until adequate blood levels are maintained and manifestations are reduced or eliminated. So just give them an oral replacement until their blood levels are up. Long-term therapy is not necessary if the appropriate dietary adjustments are made to maintain adequate intake. So if they can start eating some green leafy vegetables, food that has folate in it, There's breads and grains that are fortified with B vitamins. That's also can be very helpful for them. Then they don't need long-term therapy. Once their folate level increases and becomes in the normal level, they can be done supplementing. Manifestations of anemia disappear within 1 to 2 weeks after administration of folate. So this is easily correctable. Okay, thank you. And we'll return. We'll talk about the macrocytic hypochromic anemias.